Hello, guys. Pavel Krastev, DDS here, New Hyde Park, New York. I'm very happy to see all of you here today, and I welcome all of you. We have a special presentation today by a dear friend of mine and a great colleague and a top-notch clinician out of Germany, Dr. Andreas Van Orten. I'll introduce him a little bit later in a few minutes into the presentation. But I want to do number one, thank all of you, and we couldn't have done it without all of you. The top 100, the global summits, we had a great year. Dr. Keanu Shaw did a fantastic job, and all the regents and the board members and the dream team. I thank you all for what a fantastic year we had. We all learned, we all shared, and God bless you all, and thank you, and a hearty congratulations to the top 100. So today, guys, we're going to be talking about a very important topic, crestal sinus elevation or sinus elevation. And before we get into it, there's really something that I want to talk to the younger colleagues about. So when we lose teeth in the posterior maxilla, the sinus pneumatizes. It comes down in many cases. And then we are lacking the bone height in order to place and properly stabilize our implants. So we have to either do a lateral window sinus lift or a crestal lift. Now, as we all know, we all like to do a minimally invasive dentistry. And these days, we're trying to avoid doing a lateral window when possible and do the same procedure when possible again via crestal lift. So it's less invasive and less traumatic to the patient. So again, today we're going to be focusing on the crestal aspect, as far as I understand from Dr. Andreas, and many new techniques that he will show you guys and myself. So before we get into it, I just want to give a little bit brief review. So years ago, we used to do a sinus crestal lifts with an osteotome. So there's two ways of doing it with an osteotome. You could either drill short to working length, and then use an osteotome directly on the bony floor of the sinus and upfracture it. Right? That requires some malleting, and the malleting can cause vertigo, which is usually transient and goes away, but it's still unpleasant. So the other way to do it with an osteotome is if you drill to working length with a drill, then pack the column, the osteotomy with bone, and then use an osteotome to mallet it up. That's called a bone cushion technique. And that creates hydrostatic pressure and upfractures the floor. So once again, these days, I think most of us prefer to use a rotary device. At least I do. I hybridize, in other words. So I use several different techniques when doing the procedure, so it's less traumatic to the patient. So I typically use a rotary device to get shy of the floor. All right. And then I check to feel the floor, and then I use rotary again to actually enter the sinus, right? So I avoid the hammering and the possibility of vertigo. Then what I do is I check for membrane integrity, and then I proceed to do my elevation. So now, regarding osteotomes, I want to make a little comment here. As you guys know, I created the VGO system. That's the variable geometry osteotomes, which are manufactured exclusively by Helmut Zeff and carried in the USA by H&H Company. So osteotomes, again, can be used to carry the bone up, but I don't like to use osteotomes to upfracture the floor, so I don't hammer. So I hybridize. Once I'm in the sinus, I verify membrane integrity. Then I introduce my bony material to working depth, okay? And then I use the VGO system to carry it up and also increase the diameter of the osteotomy so that I densify the bone, thereby improving the bone quality. So that's how I do it. Now, for some of the beginners out there, and this is just something that I think is easier to learn this technique regarding the crestal lift itself. Pick a case initially with less experience that you have, let's say, 8 millimeters of bone or even 10 millimeters of bone. So when you have 8 millimeters starting bone or 10 millimeters, there's really very little that can go wrong, even if you perforate the membrane. You just put an implant either to the floor or a millimeter or two into the sinus, and that's fine. Okay, so there's not much you don't have to abort the procedure, is what I'm trying to say. So for the beginners, I recommend 8 millimeters, 7 millimeters, 9 millimeters. That's a case you can try to lift put a longer implant, and if you have a tear, just put a shorter implant in, so you're safe. The other thing that we have to touch on is these days many of us use PRF. PRF is the new way to go, the new technology. Dr. Shokun is an authority on the subject matter of PRF, and he's the pioneer of this concept. And also Carlos Morao, he's an authority, a big-time authority on PRF and all associated matters. He's got multiple papers, books, courses. I mean, I have great stuff to use as insurance. So why is it so good? So if you do have a tear, you can use the PRF membrane or a plug or whatever you want to call it. The name's not important. You can put it into the hole and repair the membrane and then introduce your graft material. So there's many nuances and many techniques. But today, Dr. Andreas Van Orten is going to be introducing a way he does it that I have to tell you, I mean, I've seen it multiple times, and it's very exciting. It's extremely sophisticated and yet interesting for the future. So I'd like to bring Dr. Andreas on the screen, and then I'd like to read his resume. Dr. Andreas, welcome, everyone. Dr. Andreas Van Orten from Germany. It's a pleasure, and in honor today, I wear my little German and American little flag. So it's a pleasure to have you, my friend, and I call you my friend because you are my friend, and we've known each other for quite some time. And I'm very excited that we're hoping that once COVID finishes, Dr. Andreas and his family will come visit us in the U.S. and stay with us, and we're going to have a couple of weeks of fun. So I'm very, very excited. And again, today is going to be, in my opinion, a great learning experience for myself. And I'm sure for many of you, once we see how Dr. Andreas does the lifts. So without further ado, let me just read Dr. Andreas' resume, and then we'll get on with the presentation. All right, give me 1 second, guys, because I got to put my glasses on, and then we'll take it from there. All right. So, Dr. Andreas Van Orten, MSc DGI DGZI. Dr. Andreas Van Orten, 1993 to 1998, study of dentistry in Munster. 1998 to 2005, assistant dentist and branch in the Gastro Roxel. And by the way, guys, if I butcher up the names, I'm sorry. Forgive me. Since 2005, based in Wotrop. Since 2016, with Dr. Dirk Krishik, Master of Science as dentist, Thursday 24. 2013 to 2016, Master of Science in Oral Surgery and Implantology. 2017 to 2019, Master of Science in Periodontology and Implant Therapy. 2005, since 2005, focus on implantology. Since 2007, focus on periodontology. DGZI, main focus of work, implantology, periodontology, CAD/CAM technologies, with a focus on template-supported augmentations and implantations and dental prosthesis fabrication. International speaker for implantology, periodontology, computer-aided dentistry. Joint clinical research projects with the Universities of Bonn, Witten, and Basel on topics of biomaterials, minimally invasive sinus lift, and implant and abutment designs. Wow, that's impressive, my friend, and welcome, and thank you for finding time to join us and share with us your knowledge and your passion. And it's exciting stuff. So, but before we get rolling with the presentation, can you please just tell us a little bit about yourself? What possessed you to become a dentist? How did it happen? Tell us a little bit about how you practice, what you believe in, what you don't believe in. We want to get to know you a little bit.
Yeah, I always wanted to become a member of the field of medicine from my very first moment I can remember. And so I started at the University of Munster when I was 18 years old. And at that time, we had the chance to do dentistry and general medicine at the same time, which isn't possible today, but which was a lot of fun. And for me, it was quite obvious that I love tiny little things. I like to go sophisticated ways. I love magnification, and maybe that's the reason why I became a dentist and not a general surgeon. So in our field of work, we never see people die when we're lucky as a dentist, and so sometimes we don't fight for lives, but we always fight a little bit for improving qualities of lives, and that's enough for me, to be honest. And I really love our job. And I admire the big guys who go to save lives, who work on an open chest to save someone's life, or who work on the motorways to save someone's life after accidents. But to be honest, for me, it's enough just to improve a little bit the quality of life, even if I'm not saving lives.
Well, that's such a great point you just made, that Andreas. And it's not a question of what we do and what professions we actually practice, or who. It's about the whole globe and what we're going through, and everyone pitches into what they do, what they're best at, regardless of race, gender, what profession, what level on the talent pole it goes on. It doesn't make a difference. We all do what we love, what we enjoy, and we all pitch in to make the earth what it is. And so I totally understand the point that you make. Now, I'd like to move on a little bit. I've known you for quite a few years now, and you've been showing me bits and pieces of how you do the sinus lifts. And I tell you, I'm very excited about seeing your presentation. So, I want you to start because I just got to see it. So, guys, let's rock and roll. Let's take a look, and then we'll come back to some questions at the end.
Thank you. It's really my pleasure, and I want to say thank you, dear Pavel, for inviting me. Thank you, Dr. Anschul, for supporting me with the technique stuff, and thank you, Dr. Shah, for having me here. So, my today's topic is mainly the minimally invasive sinus floor elevation procedures, but before we start with the minimally invasive crestal lifts utilizing hydraulic or hydrodynamic forces, I would like to give you a little roadmap for this afternoon. And at first, I would like to go back a little bit in time to show you the classical techniques which were described by Boyne and James first and were performed by Tatum, then the Osteotome technique by R.B. Summers, some modifications from the middle of the 90s up to the first decade of this millennium. And then we start with my favorite topic, and I call these techniques sinus floor elevations 4.0. And I will show you afterwards some bone substitute materials and grafting materials, base makers, base holders, with special regards to these minimally invasive techniques. If you still want to spend some time with me, we can have a deeper look at 6 to 7 cases and talk about the evidence. And after the webinar, we will have question and answers. But by the way, you can email me. You will find my email underneath my slides several times. So just mail me or just phone me. I really love to get in contact with colleagues worldwide. I like to travel, and I'm really looking forward when travel restrictions will be gone. And I would have loved to sit next to Pavel this evening, but times are a little bit difficult right now. But I'm sure in 1 year things will be completely different, or maybe not completely, but different. And so I'm thinking positive. When I planning a case, I always have to take a deeper look, because I love to perform sinus floor elevation procedures, but often there are many other techniques which can be very helpful for the patient too. And I just want to mention the conventional prosthodontic restoration. I just want to mention the concept of a shortened row of teeth, or I would like to talk about short implants, tilted implants, and even zygomatic and pleuroid implants, but time's too short, and so I will focus a little bit on some sinus floor elevations procedure. So first study I would like to cite this afternoon was performed by a work group in Germany, and it's a colleague with German, from Mainz, at the University of Mainz, and his name is Ike Schiegnitz. And Ike Schiegnitz could show that patients do benefit really a lot if they undergo these sinus floor elevation procedures. They performed classical lateral windows, and these patients' quality of life improved significantly after after the sinus floor elevation procedures. But to be honest, in between, directly after the surgery, the same patients undergo some difficulties. They sometimes have to face pain, swellings, hematoma, and edemas. And so we always have to consider what we're doing. The second study I would like to cite at the very beginning of our presentation was presented by Jan Derks, also a German guy who went to the University of Göteborg. And he investigated nearly 2,800 patients with more than 11,000 implants, really a very big study. And he could show that the odds ratio of having an early loss of an implant is about 3 when the implant is shorter than 10 millimeters, as you can see on the graph on the right side. And I know there are other studies who present other results, but for me this is a very important study because it is not performed at the university. It is performed by colleagues just like you and me in dental practice, not in a universal setting, at a university setting. And I thought it was something we should keep in mind, that if we have not very strong bone, if we maybe go for immediate loading procedures, it can be helpful to have an implant with a certain length. We could discuss the whole night about what length we should have, and you will find very different opinions. And the longer I work in our field, I see that there are many ways which lead to Rome. But for me, I feel comfortable when I have an implant length around 10 millimeters. So this is my first chapter, Tatum, and I just want to give you a brief overview about the technique. It's just classical flap preparation. You can perform the lateral window technique utilizing piezo surgery or rotating instruments. For myself, I love piezo surgery. And after you have prepared your window, you can perform the augmentation. And we've got a lot of evidence that inside the maxillary sinus, you can work with autologous bone. You can use most of the bone substitutes. The maxillary sinus is one of the places where bone augmentation is working nearly always fine. So what are my personal indications today? Different than 20 years ago, my indications to go for Tatum techniques are mostly large and combined defects or compromised surgical sites when I have to care for a fistula or when I have to care for a foreign object or a cyst inside the sinus. And I would like to show you just one or two cases which are typical for my practice today when we perform a lateral window technique. This patient suffered from severe periodontal problems and the fractured second molar, and it's obviously that we can gain a lot of vertical bone height in a very short period of time, and we will be able to perform our implantation very easily. And even in compromised surgical sites, just like in this case where you can see a cyst and a fistula, this lady suffered under a lot of problems, periodontal problems. She had to undergo general medical problems, like just like carcinomas. She wasn't in a good condition, and this wouldn't be a perfect case for a crestal sinus floor elevation. So you have to tidy up your surgical site, and you sometimes have to care for scars and tissues which are not in a perfect condition. And you can see I love to use PRF2. These are PRF membranes, and in my hands they work really perfect when it comes to the repairing of the Schneiderian membrane. And you can put a collagen membrane over it, and you can go autologous, or you can, this is a beta TCP, or you can go xenogenic, whatever you like. And I love to use a second membrane just over the lateral window, which lasts for a longer time. I like natural linked, cross-linked collagen membranes, which last for some months and not only for some weeks. And even in these cases, you can gain a lot of vertical bone height and have a proper implantation afterwards. But obviously, our patients often undergo a certain period of time where their quality of life is compromised by our work. And I've chosen this case to show you that you can also have both indications. On the patient's right side, I had to perform a lateral window technique because of several fistulas, and I had to augment the ridge too. And on the other side, I could go for a crestal minimally invasive technique. And as you can see, even with the minimally invasive hydraulic techniques, you can gain the same amount of vertical bone gain. But as you can see in the X-ray too, I utilize different bone substitute materials, and I will get back to this point later. A colleague, I've never met him. For me, he's really an idol, is R.B. Summers. And R.B. Summers published in 1993 a crestal sinus floor technique, the Osteotome technique. And I was influenced by a paper of 14, which was published in 2006. And 14 could show in his studies that if we go for a flapless procedure, we have a higher number of patients who will feel no pain. Our patients will take fewer pain tablets, and their pain will decrease faster. And I always ask myself, is this applicable for the osteotome sinus floor elevation techniques too? And I've made a little video for you and a little movie, and you can see when you use a mollet and you use an osteotome, it's quite impressive for the patient. When the patient is not sedated or sleeping, it's often painless, but it's kind of really irritating our patients. And you can use an osteotome for vertical bone height of, let's say, 2 to 3 millimeters, and you can achieve this goal very fast. But today, although I love the work of R.B. Summers, I try to avoid the mollet, and I try to avoid hammering. And there are good reasons why. And I would like to cite a study which was published by Andy Temmerman, who's working at the very famous European university in Leuven, which is located in Belgium, under Mark Hirainen, who's a very famous periodontologist. And they investigated about the influence of the Schneiderian membrane when it comes to a swelling of the Schneiderian membrane. Does it influence the volume of the graft afterwards? And I read this paper, and for me, much more interesting was the graph which I've copied on the right side of the slide. And you can see on the X scale, it's a time scale, day 0 to day 7. And on the other scale, it's a so-called VAS scale, where patients do visualize their pain score. And on the left side, you've got the lateral window technique. On the right side, it's a special hydraulic technique, which is called the intralift technique, and in between the osteotome technique. And especially for the first 3 to 4 days, patients who underwent osteotome techniques seem to have go through the highest pain scores in this study. There are some other studies who come to or who can show other results, but I've seen a lot of patients who did not like, and the green fracture pain and the hammering, it was really kind of disturbing them. And there's one group of patients where we really have to take care of. And this is the group of patients with inner ear complications, because they can face a vertigo if you use a mollet. And I've seen a vertigo twice in my life, and both patients were incapable of driving cars for 6 weeks. And this was quite a hard time for these patients. And afterwards, I gave my very best to work to improve, to avoid molleting and hammering. And so I traveled the world and took a look about the alternatives. And one alternative, which I love to utilize nearly every day in my daily practice, are the VGOs, which were invented by my friend Pavel from New York City. And you can see how smooth it is to use these kind of osteotomes. You just screw them in, and they are capable of helping you to get your bone substitute materials underneath the Schneiderian membrane and to improve the bone quality. And you don't need any water spray or stuff. It's very silent, and you've got time, and you've got perfect control. And so I admire Pavel really a lot for having developed these beautiful and wonderful instruments. And I will show you at the very end some cases where I utilize them. So the indications for the Sinus technique, when you use the mollet and the osteotomes, in my eyes, should be restricted to, let's say, 2 to 3 millimeters of vertical bone height. But they are not suitable for patients with inner ear complications. But if someone comes to other results than me, I do respect this every time. The older I get, the more I know that different techniques work differently in different hands. And this is just my opinion. And it's not a kind of disrespect to these people who have very good results with maybe the osteotome technique. But for me, it was quite a hard time when I met these 2 patients within 3 years who had to suffer from this vertigo. And so I'm really into these alternatives, and I like them a lot. So, but what kind of modifications do we find when we take a look at the years 95 to, let's say, maybe to 2005? And or afterwards. And one technique which is really new, 2014, was described at the University of Daegu in South Korea by a colleague whose name is Kim. And he did not go for a lateral trapdoor technique. Normally you prepare the lateral window and you have a kind of trapdoor technique, or some colleagues say take the lateral window and use it for the augmentation itself, or say scratch it away, or use a rotating instrument. And Kim was the first one, as far as I know, together with DS Son, who described a technique where he just cut the window out of the lateral side and set it back afterwards. And I tried it, and it's working very fine in my hands too. If the bone is not too thin, you will even have a press fit afterwards. I would recommend a very small piezo surgery saw in order not to destroy the Schneiderian membrane. And the bigger the bone is, the easier the press fit can be achieved afterwards when you set it back. And this is a technique where you can easily achieve vertical bone heights of whatever you like. Just in this case, a very fast technique, but a little bit invasive, and you have to use sutures, and the patient will be compromised, let's say, for 3 to 5 days. A technique which was described by Fugazoto at the very beginning of the millennium, and as far as I know, I didn't met him, but Fugazoto is a colleague from New York City too. He was a very clever guy, and he used a trephine, and he drilled with the trephine towards the cortical floor of the maxillary sinus, and fractured it. And in the original technique, this procedure was performed as a 2-stage procedure, but I've seen it as a 1-stage procedure with simultaneous implantation too. But in the original technique, which was described by Fugazoto, he filled the gap with a bone substitute material, and he utilized a collagen membrane and got back for a 2nd-stage procedure. A technique which I've never performed in men, just in animal cadavers, is the so-called Cassita or balloon technique. And still there are some working groups in different parts of the world who like to utilize Cassitas or balloons to elevate the Schneiderian membrane. And if you're interested to see how it works, I can recommend you a paper which was published by Kefir in the year 2007. And Kefir could show that this technique is capable of gaining bone heights up to 10 to 11 millimeters, so that you will always have enough bone in the 2nd stage to go for a proper implantation. But it was really kind of time consuming in comparison to a lateral window technique or some crestal techniques, which I would like to show you right now. This is a very heterogenic field because there are so many techniques. It's really difficult to decide which technique you would like to perform in your dental practice. And I've made a little movie for you where you can see how it works, or just some impressions. You can go with a classical flap design. You can perform it flapless. You can have more than one implant site at the same time. And I think you can see in the video how easy it is to take a deeper look and see if the membrane is still healthy and intact, or if any problems occurred. And we will get back to the details a little bit later. So The approach can be flapless, or you can perform classical flap designs, whatever you like. You just have to modify your technique. And in many cases, I like to go flapless. And one of my favorite tools to go flapless is the so-called ATP punch, which stands for atraumatic tissue punch. It's got a little blade inside, and if you leave it for a little moment, the tissue is prepared in a manner which makes it easy to have a sealing afterwards. You will see it in the videos in some minutes. One of the most important moments when you perform a minimally invasive sinus floor elevation is the moment of the first entry, or I would call it the breakthrough, which means you perforate the cortical floor of the maxillary sinus, and you must not tear the Schneiderian membrane, because you need this membrane to keep your bone substitute materials in place. And the Schneiderian membrane is the structure which is capable of the osteogenic effects. And there are many ways to do it. And the first one is to use special drills and burrs. And I will show you a technique from Austria, which inspired me a lot. It was invented by Dr. Eder and a colleague, Dr. Jesch, and together they call it the Jeder technique, which stands for Jesch and Eder, and some other techniques afterwards. They published their first case series, or their first pilot study, in 2013, and I went to Vienna in 2012, and I visited Dr. Eder for 1 week, and I assisted him for several surgery interventions, and it was very convincing for me that it is possible to have a safe and clean and a very safe first entrance, and I will show you how it works. I love to use templates, as you can see in the video. I use the ATP punch. In this case, I decided to go for a flapless procedure at the second premolar side and the first molar side. I try to get near the cortical floor, but not to break through, by utilizing a conventional 2 mm pilot drill. And this is very sophisticated. It's a very tiny pressure chamber, and inside this pressure chamber, you've got a pressure of 1.5 bar and real-time pressure monitoring. This is a special drill. It's so-called the Jeddah drill, and you perform a tapping, kind of trying to have a little haircut underneath the Schneiderian membrane in the cortical bone, and you can see the pressure is about 1.5 bar, and in the very moment you have a little scratch in the cortical floor, the pressure decreases, and you know that the water is flooding into the maxillary sinus underneath the Schneiderian membrane and is lifting it up. It's very easy, and you don't have a great learning curve. We will get back to this technique later. These days, the denser burrs are very popular. To be honest, I don't have a lot of experience as far as minimally invasive sinus floor elevations are concerned. I utilize them in these cases where I can't go with the VGOs, because when we've got patients with a with an insufficient mouth opening, or when we have to go in the second molar region, then sometimes it's nearly impossible to use the VGO because of the patient's mouth wrinkles. And then they work quite fine, but I do not have any experience in performing minimally invasive sinus floor elevations. But I saw a lot of x-rays of people who love it, and it seems to work really fine. The casket is quite popular in South Korea and also in China. And there are many colleagues who work with the casket. And the casket is a kind of drill who utilizes the bone itself after losing it to not to get in contact with the Schneiderian membrane. Second possibility of having a safe breakthrough, which I very often performed, is the utilization of piezo surgery tips. And in Europe, we've got two techniques which are quite popular. One is the Fusolift, the other is the Intralift, where it is recommended to have a first breakthrough and the first entrance underneath the Schneiderian membrane into the maxillary sinus by using piezo surgery tips, as you can see in this little movie. When I use piezo surgery tips, there are several tips which I can really recommend. In this video, it's a little round diamond tip, and I've got a lot of feeling for the bone, and in the very moment I break through, I just stop, and even if you have a little contact with the piezo surgery to the Schneiderian membrane, you won't hurt it normally. And this is what it looks like when you use a loop or a microscope or an endoscope. You will always see a kind of grayish Schneiderian membrane. Often you can see the vessels in it. When you've got a light on your loop, you can see the reflections. And in the case of a perforation, you just see a black hole. So I would say it's really very easy, or kind of easy, when you use magnification and a certain amount of light, just to have a look if the Schneiderian membrane is intact or not. Yes, this is another photograph, and you see the grayish Schneiderian membrane, and in the middle a little vessel. And this is how it looks like when you use a round tip, around piezo surgery tip, to break through the cortical floor. Yes, this is also a video, but it's hard to see in the webinar. It's much easier to see when you see through the loop or through the microscope, just like in this cases. Just give me a second and you will see the reflections. Do you see the reflections? And you don't see these reflections in the case of a perforation. You just see a black hole. After you have performed the first breakthrough and the entrance underneath the Schneiderian membrane, it's important to lift up the Schneiderian membrane smoothly. And the way which I love the most is to lift it up utilizing water pressure. It's in Germany I would call it it's Pascal's law. When you use water pressure, then you will have the same pressure at every point of the membrane. And this is the reason why I don't utilize Cassitas or balloons, where you have a point pressure, or osteotomes. In the case that you utilize water to lift the membrane, you have a very smooth pressure at every point, the same pressure of the membrane, and the risk of having a perforation decreases significantly. And once again, you can see the jetto system, and on the right side you see a kind of silicon sealing on a conical carrier, and I pump saline solution amounts of 0.2 millimeters underneath the Schneiderian membrane, and you see the pressure increases. In the case you have a perforation, the pressure will be at 0.0, and the water is just flooding inside the sinus and maybe is dripping out of the nose. But when you see a pattern like this in your real-time pressure monitoring, you can be really sure that everything is fine, and you have a chance to have a proper documentation. So it's not common yet in many practices, but for me it's a very good idea, and so for me it is very important just to spread this idea of having a pressure control instead of trying to visualize everything. The CAS kit includes a system, a component which is called the hydraulic lifter. And I would like to cite a study from Korea too about the assessment of our colleagues' subjective satisfaction, which is very high with this technique. And so I went to the Southeast, from Europe to the Southeast, just to learn these techniques. And it's quite simple. You have the green is a sterile polyurethane carrier with a hose, and you can press fit it into your surgical site and just use water with a syringe to have a very smooth detachment and lifting of the Schneiderian membrane. I would like to show you two other ways. Instead of using a conical carrier, you've got the chance of to utilize an implant-like screw, which had been shown by a German guy whose name is Kühl 4 years ago, and this is a picture of these implant-like screw with a hose, and you can bring it into the surgical site and use a syringe for the detachment of the Schneiderian membrane, utilizing hydraulic pressure with a sterile saline solution. Sometimes with this technique, the reason why I don't use it very often is that you need a certain amount of bone to have a proper fitting of the screw. I would say it's about at least 5 millimeters. And in cases of less bone, it is not possible to have a proper fit. I just tried it in cases with a lot of amount, and it's working nicely and easily. But you have to keep in mind when it comes to a less bone than, let's say, 4 to 5 millimeters, it is difficult to perform it. I would like to mention a special implant too, which is called the iRace implant. I do not have personal experience with it, but I loved the paper, and I think it was a colleague from Israel, and his name is Mayritsky, and he presented a study about an implant with an L-shaped channel inside the implant, which could be utilized for to use a liquid bone substitute material or a pasteur's bone substitute material through the implant for the lift, and you could keep the implant directly in place. And I found this technique very interesting, and so I would like to mention it today, even if I don't have any experience with it. I've got a lot of experience utilizing these piezo surgery tips, and they have been investigated by several work groups, and I would like to cite one colleague from Austria. I would like to cite him 2 times this evening, and his name is Angelo Trötan, and he's also from Vienna. It seems to be that we have a special community who likes to care for minimally invasive sinus floor elevations in Vienna, because a lot of studies were published there. And together with 2 other colleagues, one of them is Marcel Wainwright, and the other one is named Kurek, and he's from Düsseldorf. They produced piezo surgery tips in order to have a proper minimally invasive sinus floor elevation. And the 5th element, the trumpet-like instrument, is the one which is utilized to detach the Schneiderian membrane, as you can see in this picture. And I don't have this system in my dental practice because I had another one, and sometimes it's just like my family says, wow, it's not, you can't buy everything. And so Christmas is coming. If someone's watching this, and it would be a perfect present for me. I'm just kidding. Okay, and here you can see what it looks like when you perform minimally invasive sinus floor elevation utilizing a piezo surgery tip. And the numbers which are printed on the photographs, they stand for the time which they let the water flow underneath the Schneiderian membrane. And from A to D, you can see how the membrane is detached in a sheep cadaver model. And I've seen similar pictures in men with an endoscope inside, and it's getting kind of grayish when the water is flooding underneath the Schneiderian membrane. And it's very safe to use water. So perforation rate is normally, by most of the practitioners, about, let's say, 5%. A technique which is very important to mention, although I did not perform it by myself, is called the PISE technique. And it was invented in South Korea too by D.S. Son. And he's also using a piezo surgery tip with a different shape in order to lift up the Schneiderian membrane smoothly. Okay, I think it is very interesting and very important to think about classical bone substitute materials or space-making biomaterials in combination with these lifts. This is a picture of my son Nicholas, and he loves to play in the ball pool. And always when I see this picture, it reminds me of me trying to get granules into underneath the Schneiderian membrane into the maxillary sinus. And it was often that we needed something like maybe 5 to 7 minutes to perform the sinus floor elevation, and then it took up to half an hour to put the bone substitute material through these tiny little perforations underneath the Schneiderian membrane. And so I was looking for alternatives for a very long time, and I tried different things. And this afternoon, I would like to present 2 alternatives to you, because they are certified in Europe and in Asia. And as far as I know, they are FDA certified too. And the first one is a classical bone substitute material, a porcine bone substitute material, which is well known in Europe by the name of MP3. A lot of periodontologists like to use it for the regeneration of bone in combination with periodontal treatments. And this one is a little bit different from the MP3 because it's got even more collagen in it. It's got 40% collagen, and so it becomes kind of not a solid state, a kind of fluid state when you utilize it to bring it into the maxillary sinus. You need a little bit of pressure, and your perforation must be enlarged a little bit to bring it inside, but it's easy and safe and very smooth to bring it into underneath the schneiderian membrane into the maxillary sinus. And due to the high volume of collagen, you will see that it's impossible to keep the whole volume afterwards. I would recommend to utilize this material in one-stage procedures when you have the implantation at the very same time. Sometimes I have to care for patients who want me not to utilize xenogenic material or even allogenic material. And then I've got a very nice alternative, which I can present to you today. And it's a beta TCP. There are several beta TCPs, and this is one of them, which is called the Cerazorb paste. And as you can see, it's got a nice tip which fits perfectly into the ATP punch preparation, and so I can use it directly for the augmentation. When it comes to little vertical bone gains which are needed, we should discuss if we need any bone substitute materials at all. Is a blood clot enough for a minimally invasive sinus floor elevation, or do we need a bone substitute material at all? Had often been in the center of many debates, and you will find evidence, especially in the northern part of Europe, that it's not mandatory to utilize the bone substitute materials. But when it comes to, let's say, vertical bone heights which are needed more than 3 to 4 millimeters, and you don't have a lateral window technique with a trapdoor technique, and the implants are not stabilized, you can be confronted with loss of bone or with a loss of vertical bone height, which was shown by Hürzler and Zur. And the paper of Peterson and Lang cited these papers, which I've mentioned before, and they conclude that we can go without any bone substitute materials or just with a blood clot when it comes to vertical bone heights between 2 and 3 millimeters. And when you need more, you often see that the implant tip, the apical part of the implant, is inside the maxillary sinus without bone. So I would recommend to utilize blood clot only in cases of, let's say, 2 to 3 millimeters. You can gain more bone when you use PRF membranes. Pavel has mentioned the utilization of PRF at the very beginning of our afternoon, and you will find more and more evidence that you can utilize PRF in order to gain bone. I've made a little movie for you because sometimes we dentists are not used to draw blood, and so I had a vein light at the very beginning. You would not need a vein light in this case. It's nearly impossible not to draw blood in this case. But when you have a patient who's with veins which are hard to detect, the vein light can be a proper help, especially when you start to draw blood. And this is what it looks like when I prepare different PRF things. This is the so-called big membrane, which can be utilized for many things, and it can be utilized inside the Sinus 2 to care for perforations of the Schneiderian membrane, or just to keep the Schneiderian membrane in an uplifted position. On the left-hand side, you could see some moments ago little tiny membranes which are easier to be brought into the maxillary sinus. And in the very middle of this movie, you can see 3 glasses, and I will skip to the next slide. And I even recommend PRF, even if you use classical bone substitute materials in order to make a so-called sticky bone. It's a help to bring the granules inside the maxillary sinus. It's much easier, and the risk of granules which are going somewhere else and staying at the place where they should be is decreasing. My last point in this chapter are space-making biomaterials, and this is experimental. I would not recommend it for the daily practice, as you can face several problems. I will get to this when we see the X-rays. I have mentioned Angelo Trötan from Vienna once, because he was one of the inventors of the intralift technique, and he utilized collagen sponges as a space-making material just in order to keep the Schneiderian membrane in an elevated position. And I found this study very interesting, because you could see the central petal calcification of the bone. When you see the X-rays, you have to keep in mind the Schneiderian membrane is elevated by the collagen sponge and starts to produce bone. It's just the osteogenic potency of the Schneiderian membrane which leads to this calcification. And these X-rays were made after 4 months, and the next one is made after 7 months. And it's a perfect result just with a collagen sponge of 2 milliliters or 2 cubic centimeters, 2 ccm. But it's still experimental. We need further investigations to see if it's working in everybody's hand. A biomaterial which I like really a lot when it comes to periodontal questions are cross-linked hyaluronic acids, which make my life sometimes much easier because they have a very good impact on wound healing. And I utilize them for very tiny sinus lift elevation procedures, just like the 2 or 3 millimeters, because I did not utilize a blood clot itself because of the instability of the blood clot. But when you use a cross-linked hyaluronic acid, it's much more stable, and it works like an extracellular matrix for our cells which come from the Schneiderian membrane, and it's easy for them to organize and to start with a calcification. So it's harmless and very easy to perform a very small sinus floor elevation procedure, but it's still experimental. You won't find a consensus in utilizing this space-making material yet. The last biomaterial which I utilized in 2 studies right now is the so-called poloxamer and we just call it the magic gel. It's very funny and very easy to handle, because when you take it from the fridge, it is liquid, as you can see on the right part of the movie. And when it comes to room temperature and also at body temperature, it's kind of solid, or it changes to a solid state, from a liquid state to a solid state. And I read a paper in 2017. I should mention it here. It was written by Gianguido Corsellu, and he utilized this material in lateral window sinus floor procedures. And I tried to get in contact, but it did not work. And so I wrote to my local ethic committee, and we started to work with this material too, but not with a lateral sinus floor elevation technique, but with these minimally invasive Crestly techniques. And when it comes from the fridge, you can fill it into a syringe. This material it's not special. It is very widespread. It is listed as an ingredient in many materials which are widespread in the field of dentistry or in dermatology. It's very harmless, even if you swallow it when you suffer from gastroenteritis, or when you I'm looking for the word, when you suffer under esophagitis, you can swallow it to protect your tissue against the acid from your stomach. And it can be a very good idea to utilize it, and I will present to you the results of our studies right now, but it's still experimental, and you should not utilize it without an ethical improvement. And this is a typical X-ray. After surgery, the post-op X-ray, you can see a little grayish bubble around the implant. And when you see the 1-year follow-up, you can see the trabecular structures. The patient had a vertical bone height of, let's say, 3.5 to 4.5 millimeters, and was lifted up to 12.5 in just some seconds. So my conclusions in general for the minimally invasive sinus floor elevations utilizing hydrodynamic or hydraulic forces are that the patient's acceptance is very good, but you often need new technical equipment and training. The clinical findings are normally very unremarkable. You will often benefit from reduced operation time, and it's helpful to have a special bone substitute materials with a flowable consistency, or with biomaterials with special properties for these techniques, because sometimes it's very hard and time consuming to try to get classical granules inside the maxillary sinus underneath the Schneiderian membrane. And I would be glad if you just have 5 to 10 minutes more, and we will see some case presentations which we can discuss afterwards. And the first case I would like to present to you is one of my oldest cases from 2012 or 2013. I utilized the JEDA system, and at one side it was a one-stage procedure, on the other side a two-stage procedure in combination with the bovine bone substitute. And this photograph shows the condition in which the patient was when he first came to our dental office, and he was in need of periodontal treatments. He had insufficient fillings and needed prosthodontic restorations, and he did not like just to go for a new bridge, because he said it's so difficult to clean, and is it possible to have single teeth again? And I said, yes, it's doable, but it's not necessary. But he wanted to give it a try. On the other hand, he's self-employed, and he said to me, it's very important for me not to suffer under swellings or hematoma, because I have to get in contact with my clients every day to sell my goods, which is very important for me and my family. And so it was the first time I tried to lift the Schneiderian membrane with Crystal technique for 30 millimeters. And this is how it worked. At the site of the second premolar, we had a residual bone height of 4 to 5 millimeters, so it was quite easy to have a single stage procedure. But at the first molar site, there was nearly no bone left. I would say less than 1 millimeter. And this is photographed after the surgery, and this is the second stage. And this is the result after 7 to 8 years. And it's quite stable. You see there are nearly no resorptions when you utilize a bone substitute material, which is of xenogenic origin. And if you want to see the whole surgery procedure, I would recommend you just to take a look at my YouTube channel. I've prepared a little time-lapse video, and we saw part of it at the very beginning of our presentation. I utilized the ATP punch. I removed the punch. And you have to be careful. You have to do it carefully, because it is necessary to stay inside the keratinized tissue to have a proper sealing afterwards when it comes to water pressure. This is a little tiny pressure chamber. And you start to drill. We have a first entrance, which could be seen on the real-time pressure monitor. We pump in the saline solution. This is a Valsalva maneuver. We enlarge the first perforation, but remember, at this moment, the Schneiderian membrane is elevated already through the water column. This is what it looks like when you take a deep look. And then I pump back the saline solution. And once again, if you pump back liquid or saline solution, you can be sure that you have no perforation. In case of a perforation, you could see air bubbles. And this was the second stage. We lift up the Schneiderian membrane. It's a time lapse about the factor 5. I can feel the Schneiderian membrane. The residual bone height was under 1 millimeter. This was the Valsalva maneuver. I have to enlarge it. And at that time, I did not have a piezo surgery, so I utilized a round diamond burr in order to enlarge the tiny pinpoint perforation, because otherwise it would have been impossible to put the granules in. At first, I used a collagen material, then a better TCP, and now I try to fill in the granules, which takes some time. It's often that it takes just some minutes for the elevation, but it took a lot of time to get in the bone substitute material. Once again, collagen, better TCP, and then the granules. I think we took something like 2 cubic of granules for both sides, and it took something like 30 to 35 minutes, sorry. Before we place the implant, we check the diameter of the implant site in order to have a proper fitting of the implant. We set the implant something like 3.5 millimeters underneath the soft tissues at bone level, and I closed the second surgical site with a punch, with a press fit punch and the collagen membrane. The second case I would like to present to you this evening is a very new one, and we performed the first entrance into the maxillary sinus by utilizing a piezo surgery tip. We used hydraulic forces, water hydraulic forces, to lift up the Schneiderian membrane. And whenever it is possible, I try to place the implant at in a one-stage procedure, because it helps me to keep the Schneiderian membrane in place. The residual bone height was something like 3.5 to 4.5 millimeters. And once again, you can see that at the very beginning, it's nearly impossible to see the bone, the space-making biomaterial, the polloxamera. I like to work on multi-unit platforms because it allows me to have a kind of one abutment at one time procedure. In that case, we did a CAD/CAM bridge, and this is a 1-year follow-up, and you can see how the trabecular structures around the implant occur. But it's nearly impossible to see it on a CBCT. When you try to see the new bone utilizing a CBCT, it's nearly impossible because of the titanium artifacts around the implant. This lady suffered under a vertically fractured premolar and had nearly no bone in the first molar region. And she was kind of timid and asked me not to hurt her at all if possible. And so we performed a minimally invasive surgery and did the very same as before. You see, it's quite always the same, just a flapless entry. I try to lift up the Schneiderian membrane with water pressure. In that case, I utilized the so-called cervical system to have a proper soft tissue management, and then I love to screw my restorations on multi-unit platforms. And this is a X-ray control after 1 year, and you see how it starts to calcify, or you can see the calcification on the left-hand side of the patient. And on the other side, it is impossible to see the trabeculars. You just can see the bubble of the polloxamera, and it will take up to 7 months until we can see the calcification. This is a case which was very easy to perform, although it seems to be complicated. It's kind of paradox, but when you have only a little amount of residual bone height left, it's much easier to have a first entry, as you can see on the right-hand side of the patient, because it's much easier to see. And this patient was, he suffered under a severe periodontitis, and whenever it comes to periodontitis, I love to work with removable structures. And we decided to have a bar which can be milled within, let's say, 36 hours these days. And so you can even have an immediate loading with a minimally invasive procedure. and you can have a lucky patient after a very short period of time. Let's say you start on Wednesday and everything is finished on Saturday. And you can see the same procedure in this case too. It's again a template surgery. It's again a patient who was suffering under periodontitis, and so I love to have a removable structure. We had 2 implants more because he was a heavy smoker too. And this is what it looks like after we put in the bar and the prosthodontic solution. This case was quite difficult. If it had been necessary to have a lateral window technique, it would not have been easy to perform. And sometimes it's much easier to have a crestal sinus floor elevation when it comes to, let's say, I'm looking for the word. If you have a bone structure which goes horizontal or which goes coronally or laterally through the sinus floor, and it does not matter when you are going for a minimally invasive surgery procedure. This is another tip which I utilize often. It's conical and it's nearly impossible to go deep too fast. You've seen this video before. You can check the integrity of the Schneiderian membrane. You can see the reflection of the grayish structure. And I've never shown this before. It's a premiere. I utilize the poloxamer with real-time pressure monitoring in order to have the lifting of the Schneiderian membrane and to bring in the space-making biomaterial at the same time. And this is part of an RCT, and I'm very interested to see the results. Once again, the VGOs, which are perfect in these indications. You don't need any water spray. It's very silent. I am relaxed. The patient is relaxed. He's not sedated in this case. And this is much easier for them in comparison to the use of a mollet. We have a good bone quality after the utilization of the VGOs, because I often have let's say 0.7 millimeter drill or a very tiny piezo surgery drill, and utilize the VGOs to place in 4.1 millimeter implant, and it becomes very condensed. In that case, it was impossible for me to have a one-stage procedure because the patient was in need of a cortical bone plate in the premolar region, and this case has to be continued. But I found it important to show you the possibility of lifting the Schneiderian membrane and bringing in the space-making biomaterial at the very same time. And my case series with the poloxamer gel started in 2017, 2018, but much more interesting is the RCT. We have performed 30 minimally invasive sinus floor elevation procedures, and we compare the poloxamer gel in combination with a hydraulic lift to osteotome lifts. And I can already conclude that the patient acceptance is very good, and we haven't seen any adverse effects yet. It was not time consuming. It's a very fast surgery, but we have only a very short observation time in this RCT right now from let's say 6 to 7 months. But in 2 years, I can show you the results with a 1-year follow-up, and I'm very interested if we can prove the first results too. Yeah, I only had 60 minutes to talk about my favorite topic. So if you want to get into detail, please take a look at my other videos or just email me. And now it's time to say thank you. This is my my little daughter, Lily. And yeah, if it hadn't been for Corona and the COVID disaster, I would have visited Pavel this winter time, and she's 1 year older now. This picture is from last year in New York City, and I'm really looking forward to seeing you next year, dear Pavel. Thank you for your time. I appreciate it a lot. It's Saturday afternoon, and it's not normal to hang on for such a long time to care for dental stuff. So thank you very much. Thank you.
I tell you something, my brother. I got so excited from your presentation, I changed jackets. You see, I started off with one jacket, now I put the American jacket. Man, that was like what a review you gave. What a synopsis of the past, the present, the future. The Jether system, I mean, I got to tell you, I'm sold on it. I need to try it. I need to play with it. I'm looking forward to playing with it. To me, that's a no-brainer. I mean, period. You know, there's many systems out there, and you know, as most of us who do Crystal lifts, we learn from each other. Each one of us has a nuance of doing it one way or another, and you know, each system has a limitation. For example, you mentioned Versa, and Versa, I personally don't use for whatever reasons. But the problem when you're introducing bone into a hole and you're rotating it inwards, you have no way of knowing whether there's a rip, there's a tear, how much bone is going up. You're not taking into consideration how much working length you're dealing with. There's so many variables. Plus, when you are spinning a handpiece in reverse, in my opinion, humble opinion, I should say, you're generating heat. Okay, when you're using a sharp drill to cut bone, you're cutting bone and you're not generating heat as much. Regarding the casket, I love it. I use it, as I said to everyone, I hybridize. So I usually start off with the casket until I get into the sinus. And then I use the VGO, which I want to talk about for 2 seconds. I use the VGO not to mallet into the sinus. We have a posterior kit that is specially designed with a special formula, the taper, so you don't force it and fracture the crest. I use the VGO only to increase the diameter of the hole. I don't use it, and I also use it to carry the bone up. I don't use it to up fracture. So as you said, I don't like to mallet. Malleting is, I think, old school. I mean, I would love to see Helmut Zeff manufacture the VGO kit with a ratchet, with a thread for the posterior. For most of you that know, currently we only have an anterior kit with a thread, and I'd like to see a posterior kit with a thread. So once we get into the sinus, we can use the advantages of the patented taper, the VGO system, to increase the diameter of the hole and improve the bone quality. So the casket, I'm going to get back to that because I love using it. But the problem with the casket that I have is when you hold that little green nozzle, you can't form a perfect seal. And it leaks out through the sides. And then, you know, when you're testing back to see if you have the bubbles coming back to indicate a perforation, it's very difficult because if you don't have a good seal with the rubber stop at the bone contact, then you don't know if it's bubbles coming from the sinus perforation or if it's bubbles from the lack of seal. So that's the problem I have with the casket. Other than that, I love it. I use it in all my Crestal lifts essentially because I hybridize, you know. But man, what are in my opinion, I tell you, I want to get my hands in the Jetta system. I want to try it. I think it's the future. I think there's so much potential there, and plus the bone sips that you introduced is fantastic. That I want to play with and try. So you know, I want to open up the podium to any questions. And once again, I tell you, I this was like I bow down to you. and thank you for such a wonderful presentation, man. That was
No,
fantastic.
I thank you. It's my pleasure for being here. It's really an honor to be part of the Global Summit community, to be part of the Doctor to Doctor community, and so I appreciate it a lot to spend my time with you and the other colleagues. And I'm looking forward to getting in contact personally again next year.
Thank you, Dr. Van Orten. And do we have any questions, everyone? Anyone questions for Dr. Andreas? I guess not. So, my friend, look, I wish you guys in Germany a Merry Christmas, a happy holiday. May you be healthy. And Global Summits, thank you so much we had a wonderful year, Dr. Shah, the regions, the chairpersons, and ladies and gentlemen, thank you so much. And I tell you, God bless you all, and love you all. Thank you.
Bye.
Bye.